Thank you, ladies and gentlemen. We'll go ahead and get started. Apologize, we're running a couple of minutes late. We had a few technical difficulties there. We had to rearrange some furniture with all these budget cutbacks. We were having to move furniture around ourselves and everything, and we're missing a table. We hope it'll show up any minute now. So, but we're glad you're here, and we appreciate your interest in what we're about. So, we're going to go ahead and get started. Excuse me. And our first presenter will be Karen Minyard, and she's going to talk to us about some health care reform and everything. So, Karen, I think if you could use the podium right there, maybe, would that work?
Testing. All right. Thank you for having me here today. I'm excited to be able to share information with you. Some of you know that I've been working with a team over the last year of about 12 people who have been trying to understand what is actually in the 906 pages of the health reform law. We divided it up, we read it all, we made summaries of it, we created policy briefs, and have been trying to help folks understand what it says. And so one of the things that we've done is to put together a summary that shares the information in the Health Reform Act and puts it into basically 4 chapters. And I have the 5-minute version, the 10-minute version, the 45-minute version, or the 3-hour version. And today I'm going to give you a kind of a short version of the overview, and then talk a little bit about the implications for the state and just a little bit about the health insurance exchange. We do have the full presentation, which you have in your packets. We do have the full presentation with the notes on flash drives. So if there's anybody in the audience today who would like to have the full presentation with the notes and other materials that might help understand some of what's in the health reform law or help communicate it to others, give me your card or send me an email, and I'll be happy to share that with you after we're done. So this is going to be the 906 pages quickly. It would be, let's see if this works. I'm not quite sure. I think I need a little, oh, there we go. So this doesn't quite seem to be talking, but maybe it'll work now. So just a little bit of background. Some of the terms that are used in health reform frequently are, there's a lot about various levels of federal poverty, 133%, 138%, 400%, and so that's something that is frequently included. And you might hear different numbers, and that's because the poverty level is different if it's a family of 1, 2, 3, 4, all the way up to as many family members as there can be. The high-risk pool is a place or an opportunity for people who have been denied coverage to get insurance that's more affordable to them. It's something that was implemented early after the law was passed, and people in Georgia are eligible for participation in the high-risk pool if they're interested. The Health Insurance Exchange, which we're going to talk a little bit about, is a store or a website where people can purchase insurance, and in the health reform law they'll get a subsidy if they are up to 400% of poverty, which is the insurance subsidies. Something that's been the source of a lot of controversy is the individual mandate, which requires people to have insurance, everybody except those who meet certain requirements to have health insurance. And then the essential benefits are a basic set of benefits that are required to be part of the products that are offered in the insurance exchange.
Karen, let me stop you just one sec. We've got some folks having to stand up across the back, and if y'all see some extra seats, you're welcome to them. We don't want y'all to have to stand up back there, so just go ahead and find you a seat if you can and be seated, and we'll go ahead. Excuse me, Karen.
I'm going to stand right here for a minute, because I can't seem to get that to move. So, Chapter 1. Oh, okay. So did it move?
Yes.
So what did you do?
Just page down. I think it's just a little bit delayed.
Do you go to the next one?
That's not working. Just continue. I'll get it.
Okay. So the first chapter is more about how Georgians would be covered, and with this, you can see that currently about 57% of the folks have employer coverage, about 19% are uninsured, other is Champus and other military coverage, Medicaid and Peach Care, 12%, individual 4%. Early estimates of what it would look like if you took the law and put it on top of 2008, so that you're not dealing with different kinds of growth, you're not dealing with some of the things related to the economy, but you take 2008 and put the law on top of it, then you would have fewer folks with employer coverage, fewer with individual coverage, more in Medicaid and S-CHIP, the other stays the same, the uninsured goes down to 5%, and 14% of the population of Georgia would, in this scenario, be eligible for the exchange. So this looks at a beginning idea of how things will change. It's not very... The next, so that's Chapter 1. Chapter 2 is about the money. And in this chapter, what we're talking about is the very big picture of the money. So when you look at the law and the documents that have been created by the Congressional Budget Office and others that look at the money related to the law, then what you have is about $1 trillion would be spent over a decade. And that $1 trillion would be spent approximately half in insurance premiums and subsidies for people into the exchange who are up to 400% of poverty, and half in the Medicaid expansion. Now, it's different state by state depending on the makeup of the population, and we did some early estimates about what kind of money would that mean in Georgia. And the early estimates are that about $1 billion per year would come into the state in the expansion of Medicaid per year, and about $1.9 billion would come into the state with the insurance premium subsidies. We've done those estimates for some other states, and for example, Mississippi was one of the states. Their information, their data was flip-flopped from ours. They had about $1.9 billion in Medicaid, in part because of the poverty level of their population and the cost of their Medicaid program, and they had $0.7 billion in the exchange, because they have less people that fall into that category. So overall in the nation, it's about half and half, but some states will have more one way or the other. So you've heard all that's been said about the health reform and the CBO markup, that health reform is deficit reducing. So that means if we're going to spend $1 trillion, $1 trillion has to come, a little more than $1 trillion has to come from somewhere to pay for that. So the $1 trillion in the markups that the CBO did are split about half and half between savings in Medicare and the fees, taxes, and penalties. And so changes in the Medicare Advantage program, holding increases in Medicare at 2% when they've been at 4% over the last decade, to 2% per year. Some of the cost efficiency things are estimated to make up about half of that money, and the other half is the fees, penalties, and taxes. People who don't pay the taxes, like the taxes that will go into effect for a higher contribution to Medicare on our paycheck, those types of things. So that's Chapter 2. Chapter 3 is about the 4 components of health reform. And those are changes in public coverage, changes in private coverage, improving health care quality, and improving health. Just about everything in the 906 pages can be put into one of these areas. And so I'll just say just a few words about each one. The first, the public coverage, Medicaid expansion. This is the situation where all the people, no matter what their conditions, who are up to 133% of poverty would be eligible for Medicaid. The reason why this picture is a man is because the men are the ones who have probably been the least able to have coverage under the Medicaid system as it is now. And so those men that are up to 133% of poverty who have not, because it's been women and children, so childless couples and men have not had an eligibility, will be the ones that have a big impact. Everybody will, but that's part of why we picked that picture. Then comes the changes in private coverage. This is a big area because it includes some changes in regulation so that there's community rating rather than risk-adjusted premium, no pre-existing condition exclusions, no lifetime and very limited annual benefit caps, prior approval of rate increases, mandatory medical loss ratio of 80 or 85% for insurance companies. It's one thing to kind of read off that list. It's another thing, which I'll say a little bit more about later, is to think about how we would actually operationalize these things. Because a lot of the work of like prior approval of rate increases for insurance companies, or checking about the mandatory medical loss ratio, or certifying the plans and the exchange, will fall on our state. Depending on how we structure it, we will have responsibility for that. Other things about the health insurance exchange, this shop, this store, I think of it as a big store with 2 departments, one for individuals and one for employers. And it establishes common rules for benefits and pricing, offers consumers a choice of plans, provides consumers information about their choice, facilitates plan enrollment, and administers the subsidies. So that is kind of about the exchange. The other side of the part to the private coverage is that small employers are potentially eligible for subsidies. This is something that began last year. So small firms with low-wage workers who offer insurance are eligible for a subsidy that can cover up to 30% of the cost of their offering insurance. The people who will have access to the subsidy in the exchange are those people who make up to 400% of poverty, which is $88,000 for a family of 4. Another part of health reform is improving health care quality. This is an attempt to use best practices, to streamline the way things work, to save money in Medicare. It's under this category that the denial of payment to hospitals for patients that are readmitted within less than 30 days, and not paying hospitals when there is infection a hospital-acquired infection, and a lot of the things related to the accountable care organizations and organizing care in a way that there is efficiency and quality and attempting to measure that. A lot of what's needed related to this is going to come from having good electronic information. So the electronic medical record and other systems of having information are going to be important for this part to be able to be realized. A lot of people who are in the public health world are pleased to see that there is attention in this law to issues related to improving health. And one of the 10 titles is totally focused on improving health. There's a national health strategy, there's research in public health innovation, there's mandatory preventive care that has already been put in place, and there's a focus on healthy communities. So that's Chapter 3. So you've had Chapter 1, how are people going to be covered, Chapter 2, the big picture of the money, Chapter 3, what are the key components, and then Chapter 4 is the timeline. And we have information about the timeline, some of the things that have already gone into place this year or last year in 2010 were the high-risk pools, the no cancellations, lifetime coverage limits, or pre-existing conditions for children, the federal reinsurance for early retiree health insurance, group health coverage up to age 26, and the premium reporting requirements. Also, the tax credit, the $250 rebate for Medicare, and the 10% tax on indoor tanning all went into effect last year. A lot of the things that are in effect in 2011, 12, and 13 are around improving quality, beginning some of the tax and spending changes, and the big changes occur in 2014. That's when the coverage expansion occurs, the mandates are enacted, and all the additional limits on fees and incentives. And then there are a few things that happen after 2014, but 2014 is the main place. So there's the 4th chapter, the timeline. So that's 906 pages in just a few minutes, and I'll try to answer any questions, and then I'll tell you a little bit about the implications for the state.
Okay, I bet we've got a few questions. Representative Gardner, I think you had a question, didn't you?
Thank you very much, Mr. Chairman, and thanks for a wonderful summary of 9,000 pages.
900.
900, whatever.
Sometimes it feels like 9,000. And I bet we'll have 9,000 pages of regulation because somebody was telling me about when we got children's health insurance, when that law was passed, the law was 4 pages long, and the regulations that were written were 1,000 pages. So if we've got 900 pages of law, then what does that mean about how many pages of regulation?
Probably 9,000.
Anyway, more than you wanted to know.
One of the things I'm hearing a lot about is the pre-existing condition insurance plan, and have had some constituents who've gotten covered by that. When you're talking about the high-risk pool, is that what you're talking about? So the PRECIP, is that what it's called, the pre-existing condition?
Well, it's when people have been, when people have been denied coverage, then they become eligible to purchase in this pool which subsidizes their coverage. And we had a choice at the very beginning to offer that pool, that high-risk pool in Georgia, or for our folks to be involved in the national high-risk pool. And we made the choice for them to be involved in the national high-risk pool. So they go through healthreform.gov and can find what's available to them.
So we have people in our state who've already been enrolled in this program, and are they?
I don't know for sure about that.
I know that we do. I just wonder about the subsidy. Is it unlimited? Is it based on income? Is it all federal dollars?
It's federal dollars. It is actuarially based. makes their premium sort of an average as opposed to the high level that it would have been. But it's still a substantial premium that they pay to be a part of it.
Okay, thank you.
Representative Shelton.
Yeah, thank you. I just have a couple of questions. I probably should know this, but just want some clarification. I know one of the slides you showed how under current law, 50% of those insured receive insurance from the employer, and under the new law, it would be 54%. I guess really the main thing I'm interested in is the Medicaid. Peach Care goes from 12 to 17. And is that, I know eligibility, I'm assuming that would be from changes that would be required in eligibility. And is that 400%? Or is it, what will be the new eligibility rate?
Well, I mean, there's a lot of complication, and I'm sure the folks from DCH will help with the very detail of that. But what it says is that people who are up to 133% of poverty would be eligible for Medicaid. So all the people who now are not eligible would become eligible, and that's where that increase happens. In 2014. It's everybody.
Do we have any idea how many additional healthcare providers we're going to need in order to have enough doctors to provide care?
Well, you're bringing up what I think is one of the big challenges of this, and we have done a little bit of back-of-the-envelope number that I'll share with you. Currently in Georgia, we have a high shortage of primary care physicians. We are designated specifically in the law as one of the states that receives special attention when it comes to the reallocation of residency slots, primary care residency slots, because we have such a big shortage. Our shortage is probably about 350 back of the envelope, give or take, primary care physicians. Our estimates, given how many people would become covered and what we would anticipate based on the literature of newly insured people, what their demand would be for primary care, gives an estimate that that shortage will be doubled.
Well, thank you.
Other questions? Here, I've got one for you along that same line. When we talk about the shortage of the primary care physicians, is it a real shortage, or is it just a maldistribution of the shortage of the primary care physicians?
I think in the primary care physicians, it's a shortage.
Why would you think we have that shortage? Is it the income level of the primary care physician as opposed to a specialist? Or
if you look at some of the things that are the provisions that are put in the law to try to deal with this problem, I don't think there's enough there to really deal with it completely. But one of the things is for the payment for primary care physicians to be increased to be equal to for Medicaid to be equal to Medicare during 2013 and 14. Loan repayment, scholarship programs. Most all of what's in there is trying to increase the financial incentive for being in primary care.
Let's see, 19, Representative Gardner.
I've been thinking about how we're going to find enough physicians and other practitioners to deal with this additional population too. And I was thinking about the mental health patients who currently are paid for totally by state dollars, but they are being treated by somebody. They're just not getting any Medicaid patients. So does that make the shortage that you describe less severe or not? I mean, these are, if people, I mean, not to question whether there's not a shortage or not, but the question I have is, aren't some of the people who are not currently counted getting treatment somewhere already, and aren't those same medical providers going to be providing the care, only they're going to be paid by Medicaid, and in the case of mental health with federal dollars instead of state dollars?
I haven't done any estimates about the shortage in behavioral health and the impact. I know that the folks that are providing behavioral health care, especially to people who are disadvantaged are very concerned about how this is going to play out, how the money will move around, and how they will be able to serve and organize things. It's an area that needs a lot of attention, but I don't have the answer.
So it will, I mean, it will be reorganized. The question is how severe will the shortage be, I guess, is what I'm wondering about. Thank you.
Any other questions?
So could I say a few more things?
Sure.
One of the things that we've been thinking about and talking about, and one of the briefs that we did, was really focusing in on, so what does the state, what could the state do, what does the state have to do, what are kind of the issues around health reform? So I asked the team to get their title of the law and to go through it again. And this time to pull out everything in there that was either an administrative or a legislative activity or decision or question to be answered. And there was a lot. And it fell into a number of areas. Obviously, insurance. And this has to do with starting in 2010, the premiums being reviewed, the situation about the insurance companies having to spend at least 80 to 85% of the premiums on medical care. And so there's a lot related to insurance. And then the next part is the health insurance exchange. This, again, has a big impact. Our state has received a grant to look at this. At the Health Policy Center, we've been involved in doing some of the background research that would help provide information that might help with some of the decisions that the state has to make. The health insurance exchange is probably the number one thing that people are talking about. It's probably one of the most immediate things, and I have just a little bit more information about that. Then there are all the changes in Medicaid and S-CHIP, and they are a lot. There are the things that are obvious, like the expansion of Medicaid. There are options to expand Medicaid. There are requirements to implement Medicaid fraud, waste, and abuse programs. There are, for example, things related to offering smoking cessation to pregnant women. I mean, there are a lot of things that are related to Medicaid. I think probably in our sheet that had all the list of things, several of the pages were just only Medicaid changes. So there's a lot there. And then there are the things about prevention and wellness, the requirements related to that, and some opportunities. There will be some community transformation grants, which will be competitive grants to states and local governments and community organizations to implement, evaluate, and disseminate community preventive services. We're expecting that guidance to come out very soon and are hopeful that some Georgia communities or the state might be eligible for some of that prevention and wellness support. And then there are the issues related to workforce. And we've already kind of covered that. So, okay.
I just know you were talking about the insurance, and it just definitely struck me. I don't know that you didn't really answer the question, but I have to ask. I think one of my obvious concerns is the it's interesting that we're calling it private health insurance coverage when we're basically mandating so many things to a specific industry, and I don't know if there's another, is there another business that we require that they have a loss ratio of 80 to 85% other than insurance companies?
I haven't. That's not. There's nothing else in this law about that, and I haven't seen that. It might be. It might exist, but I don't know of it.
Okay. Thank you.
Karen, I've got one question for you, and I'm not sure that you're who I need to ask this to. It may need to be to the department, but from your study of this new law and the way it's going to be implemented now, can you give us your best guess as to how much money the state is going to be on the hook for to provide the obligations that we're going to have in 2014 as opposed to where we are now, how much more it's going to take to meet these obligations? Have y'all looked at those numbers?
There has been a lot of looking at those numbers, and I think that the commissioner is going to be the best able to share that with you. There has been extensive exploration of all the nuances of that.
Okay.
So,
Okay. Any other?
but I could say one general thing. We will, in 2020, have to pay 10% of the Medicaid expansion. And that starts out where we don't pay any the first 2 years and then gradually moves up. So that's kind of a basic, but there are a lot of other complications and costs that don't fall into that little part of it.
Last question, Mr. Chairman. In terms of the implementation of the exchange, I know the governor has put some bonding money in to bring down federal dollars for eligibility of a computerized eligibility system for Medicaid and for Peach Care. Will the eligibility for the exchange be part of that system? I mean, do you know in your work with the exchange group whether that's anticipated?
Well, I don't, there is a health information part in the governor's office that's looking at that part of the exchange. Mm-hmm. And there are a lot of complications related to that because there's all the eligibility that has to be done around the exchange. It needs to coordinate in some way with Medicaid and Peach Care, and our Medicaid and Peach Care systems, that all is going to have to be worked out. So there is a big piece of work. And then there's also the issue of people who are either in the individual part of the exchange or the employer part of the exchange. So there are massive information technology needs in order for this to run. And I know from my work in some other states that most states' current eligibility systems are older and were not structured to handle this kind of growth or change. So it's going to require major revamping in most states to work on that.
But it would make sense to have one eligibility system, whether it's for Medicaid or Peach Care or the exchanges?
It would make sense that it works together.
Yeah.
Okay, Karen, thank you very much, and thank you for all the information you gave us, and especially the little blue book. That's been real helpful to me.
I wanted to say one more thing.
Okay,
if you
go
let
ahead.
me.
Sure.
One of the things that I wanted to just say a little bit about is this whole issue of the health insurance exchange. One of the things that you have in your folders is a model act that has been released in the last few months that describes the legislation that a state might do in order to implement, authorize the implementation of a health insurance exchange. Also in your packet is another longer document that adds some choices to that and explains some things about it. And you probably say to me, this is too much information for right now, but it's kind of the basic, up-to-date, published information about the exchange. And so the kinds of things that states have to decide about are the governance, the exchange functions and the relationship of the exchange to the health insurance market and to the Medicaid. And this is an area where there are some very complicated and difficult choices that will have to be made. And one of the things that we've talked some about is what do we want for our state, or what might be the options as it relates to our state. And so I'll just show that last one. When you think about this, it's kind of like how can we as a state have access to coverage for as many people as possible? How can we support provider viability? How can we build real competition in the insurance market? How can we make Georgia small business friendly? And how can we promote healthy families because of all this churning that's going to occur? And so these kinds of things, and one of the articles that I was reading last night in preparation for this was the 8 difficult questions that states have to answer. And so that seems to me to be the next big work, which is kind of what are our priorities, what do we want for our state, and how are we going to answer these 8 difficult questions as we think about putting it into a document that ends up possibly being some type of enabling legislation.
Okay. Does that finish your presentation pretty much? Good. Well, thank you for being with us and a lot of good information that you brought to us. We appreciate you being here, and thank you. We're going to take just a break, a minute or two, while we prepare for the commissioner to come, so we'll just sort of stand at ease for a moment till they get set up over there. Okay, folks, if we can have your attention, we'll go ahead and resume with our presentation, and we'll call on Commissioner Cook. Commissioner, glad to have you with us, and we look forward to hearing what you have to say.
Thank you, Mr. Chairman, members of the committee. Good to be with you again today. I'll be presenting today the Governor's proposal for the FY 2012 budget for you. I have several slides here that I will go through, and we'll skip over several slides, I should say, that have been presented to the committee before. And I'll go through those quickly. The first slide is one of those where you can see where the various portions of the department's budget are, and obviously the low-income Medicaid and age blind and disabled are the two major populations in the budget. Again, as I did in my last presentation, I believe you have a copy of the handout here. The line item in the budget is coordinated with both the dollar change from the base in the first column, labeled FY12 changes, and then your tracking sheet reference is next to that. In the area of department administration, you can see item 1 is an increase in funds to reflect an adjustment of the employer share of the employee retirement. That's an additional $24,000. Number 2 reflects a change in the adjustment of workers' compensation premiums of $42,000. Number 3 reflects an adjustment in the telecommunications expenses as projected by the Georgia Enterprise Technology Services of $1.2 million. Number 4 is a transfer of funds related to the transition of the department, the Division of Public Health over to DCH, and this relates to telecommunications and software licensing. That's $2.5 million of additional state funds. Number 5 is replacing general funds with funds obtained from the fraud control with regard to global settlements of $1 million. Number 6 is a reduction of $2,000 resulting from replacing general funds with federal funds that were attributed to the nursing home eligibility online processing system. Number 7, you'll see this throughout the budget, a reduction in personnel services in this area, $147,000 for FY12, and in number 8, reduce expenditures related to a consolidation of office space of $62,000. Item number 9 relates to reducing funds for computer contracts related to the transition to the new MMIS system, and that's about $5.8 million in savings that we expect to see in that area. The next area is adolescent and adult health promotion. I went through the program metrics as we talked about last time relating to mammograms and Pap tests, etc. Item number 1, there again is additional state funds of $8,000 for the employee retirement system. You can see again a reduction in personal services of $118,000. Item number 3 is reduction in operating expenses of about $358,000. Item number 4 is to realign TANF funds based on prior year expenditure. You can see that we do that in the budget. We replace in item number 5 general funds with tobacco settlement funds. That's about $87,000 in item number 5. Item number 6, we reclassify other funds as federal funds in accordance with the state accounting financial management policies and procedures. Item number 7, we reduce funds for a variety of contracts in the amount of $150,000. And item number 8 is a reduction in programmatic grant and aid to county boards of health related to adolescent and adult health promotion of just under $36,000. The next programmatic area is the adult essential health treatment services. Again, these are services related to providing cancer treatment services and treatment and services related to stroke and heart attack. In item number 1, you can see again the increased funds regarding the employee retirement system of $4,500. Number 2 is to replace state funds with tobacco settlement funds. It's about $138,000 in this category. Item number 3, recognize contract savings by moving those hemophilia clients to the new federal pre-existing condition insurance plan, and that is an ongoing process. I understand that that will be about $680,000 in savings to move those clients over to that federal insurance plan. Item number 4 is to transfer the refugee health screening and testing sub-program to the infectious disease program. That's an adjustment of about $967,000 to a different program. The next area relates to emergency preparedness and the trauma system. As you can see, like the FY11 budget, there is a reduction there. There's an increase related to the employee retirement system funding there, but a reduction in funding of $754,000. My understanding that the amount appropriated would be equal to what we're obtaining from the super speeder fines. The next programmatic area is epidemiology, related primarily to public health. Item number 1, there is again an increase in funding related to the employee retirement system of $20,000. Item number 2 is discontinuation of certain laboratory testing. This relates to AIDS testing, and then in other parts of the budget you'll see well water testing and fluoride testing, and those are tests that are available in the private sector but would not be duplicated. Our funding for that from the state budget in this area, programmatic area of epidemiology, would be reduced almost $22,000. Item number 3 reflects the loss of federal funds related to the expiration of stimulus funds of about $200,000. Item number 3, again, is a reduction in personal services of approximately $158,000, and again a reduction in programmatic grant and aid to the county boards of health of about $141,000. Item number 6 reflects the discontinuation of the stimulus funds related to FMAP available to the Poison Control Center, and we are adding an additional $212,000 to replace that in state funds. The next area relates to health access, healthcare access and improvement. The item number 1 relates to an increase in funds to reflect an adjustment again in the employer retirement system of $23,000. An adjustment in the workers' comp premium is item number 2 of $400. Item number 3 is to reduce the one-time funds for the Erlinger Air Force ambulance program. That's a reduction of $600,000. Item number 4 is to recognize savings from the integration of health improvement and public health programs of $623,000. These are areas related to the Office of Rural Health, Health Planning, the Georgia Volunteer Doctors Area, and Health Information Technology funds. Item number 5 is to reduce fundings for the local AHEC, the Area Health Education Centers, of about $106,000. The next area of the budget is healthcare facility regulation. As you know, we license and inspect thousands of facilities across the state, hospitals, nursing homes, ambulatory care centers, etc. In this area of the budget, again, you can see the adjustment in the employee retirement system, a reduction in travel of $128,000, a reduction in state funds of about $90,000 related to eliminating the funds for adult daycare licensure. Item number 4 relates to reducing funds that were, as I understand it, included in the appropriations bill last year for 6 new positions that would not be filled. That would be a reduction of $478,000. The next area relates to immunization. As you can see, and I mentioned at our last meeting, the state of Georgia provides almost 2.5 million immunizations per year. In this area, we have, again, the increasing the funds for the employee retirement system of $1,900, and we're reflecting the loss of federal funds due to the expiration of stimulus funds of $2.4 million, and that brings us back to the base budget there. So we will pick up those expenses for the loss of stimulus funds. In the Indigent Care Trust Fund, which is the next programmatic area, we are reflecting the loss of federal funds due to the expiration of the stimulus funds again, and that's about $713,000. In the area of infectious disease control, again, these are related to HIV and other infectious diseases. In the governor's budget, again, you can see an increase in the employee retirement system share of about $57,000. Item number 2, to redistribute the refugee health screening and testing from Adult Essential Health Treatment Services program over to the infectious disease program. Item number 3, again, we discontinue the laboratory testing in this particular area, and that results in a savings of about $421,000. Infant and Child Essential Health Treatment Services, again, we went through the program metrics last time related to physical assessments and health screening for children and infants. In this area, in item number 1, again, the employee retirement system funding of additional $15,000, reducing personnel services of about $205,000 is reflected in item number 2. Item number 3 is to amend the regional tertiary care center contracts to include provision of the minimal level of prenatal services, so we reflect that change in the budget. Item number 4 is a reduction of about $450,000 in grant and aid to the County Board of Health. Item number 5 reflects the loss of federal funds due to the termination of the stimulus funds, the ARA funding there. That's about $10 million in this particular programmatic area. Item number 6 reflects savings related to the Babies Born Healthy program, which was terminated in June of last year, and those savings will be reflected in the FY12 budget of nearly $3 million. The next programmatic area is the Infant and Child Health Promotion area, providing education and other services and nutrition to infants and children. In this particular area, again, you see the item number 1 is the increased funding for the retirement system and a reduction in staff and personal services, which totals about $835,000 as reflected in item number 2. Item number 3 would be a reduction in operating expenses associated with that of about $479,000. Item number 4 is to recognize the contract savings in this area by moving the clients from this area over to the new PSIP program for hemophilia clients. That is about $653,000. And again, another savings of about $20,000 by reducing funds for certain contracts in that area. The next area are the inspections and environmental hazard control related to public health. And item number 1 is, again, increased funding for the employee retirement system of $14,000. Item number 2 is the other area where we discontinued lab testing for a savings of about $55,000. Item number 3 is a reduction in staff of a little bit over $37,000 and a reduction in operating expenses of about $213,000. The next programmatic area is the public health formula grants for the various counties. As you know, we generally spend around $61 million for general grant and aid to counties. The FY 2012 budget calls for a reduction of that of about nearly $2.5 million. In vital records, you're all familiar with the vital records program. The two areas there are the adjustments made for the employee retirement system of about $20,000 and the reduction of personnel services of about $153,000. That brings us to the major area of Medicare and Peach Care. I have shown a couple of these slides several times regarding the savings and the composition of the CMO population and the providers. So let me get to the areas of the budget here. In item number 1, and this is the age, blind, and disabled category of Medicaid, eliminating the optional benefits. I guess I would mention in the FY11 budget there were no cuts to providers either in the optional benefit program or the reimbursement rates. That is different in the FY12 budget. There are some reductions there. And item number 1 relates to that, eliminate the optional benefits coverage for adult vision, dental, and podiatry services. That saves about $6.1 million. Item number 2 is to reflect the loss of the federal funds due to the expiration of the American Recovery and Reinvestment Act, the stimulus funds, about $52 million. Item number 3 is to transfer about $1 million of funds from the Department of Corrections to Medicaid to reflect the relocation of some medically fragile offenders who would be paroled or discharged from corrections into a nursing home that would be available to those particular inmates, and then we'd be able to draw down Medicaid funding on that, so that would assist with some of the budget problems in other areas. Item number 4 is to increase existing member co-payments to implement the new member co-payments and the TEFRA option. That's about $3 million. Item number 5 is to reflect an increase in the federal financial participation. That's the FMAP, I believe, and we save about $5.1 million due to that federal adjustment in payments. Item number 6 is to provide funds to reflect the revisions in the National Health Reform Act, the Affordable Care Act, that reduces drug rebates in the fee-for-service area. We actually added an additional $7.7 million in this particular area, but we save that in the managed care area of about $12 million, so we net a benefit of about $4 million. You'll see that in the later portion of the presentation. Item number 7 is to reduce the Medicaid reimbursement to various providers accepting hospitals and home health community-based services. That's about $6.7 million. And finally, about $8.5 million of funds we expect to be derived from various drug company settlements, which would be allocated to this area of the budget. Item number 9 reflects savings from the elimination of some underperforming contracts related to disease management. That saves about $10 million. Item number 10, to restore funds from the one-time reduction in the FY 2011 Part D Medicaid clawback payments. That's about $86 million. Item number 11, to reflect the discontinuation of the increased funds that we had received from the stimulus funding to support Medicaid in this area of the age, blind, and disabled. We would be replacing those with state funds of about $362 million. That takes us to the low-income part of Medicaid. Item number 1 is, again, tracks many of the same things for age, blind, and disabled. Eliminate the optional coverage for adult vision, dental, and podiatry services for savings of about $864,000. Item number 2 is to reflect the loss of federal funds due to the expiration of the stimulus act. That is about $12 million in this particular area. Item number 3 is a reduction of expenditures related to member co-payments. That would save about $360,000. Item number 4 would reflect the increase of the federal FMAP provisions. We would save about $4.5 million due to that increase in the FMAP. Item number 5 is to reflect projected payments, which are a little bit less than we had anticipated related to the hospital provider payment collections that was enacted last year. That was about $4.8 million in lower collections than we anticipated. Item number 6, to reduce Medicaid payments to providers, excluding hospitals and home and community-based services. That would save about $6.3 million. Item number 7 is to reflect of about $1.5 million in savings attributed to settlements from the drug companies. Those would be national settlements. Item number 8, to reflect savings from the implementation of the Planning for Healthy Babies program. Again, that's about $9.3 million. And number 9 is to remove the Care Management Organization reimbursement floor, which relates to the way CMOs and others pay for hospital procedures and other services. That's about $4.5 million. Item number 10 reflects reduction in funds related to the federal health reform bill, and that is the counterpart to what I mentioned earlier related to the drug rebates. That's where we see the $12.7 million in savings on this side. Item number 11 is to reduce the state funds to reflect the one-time retroactive reimbursement for the federal share of the MMIS conversion. That's about $15 million related to the certification and payment of the once our MMIS system is certified. Item number 12, to reflect anticipated performance bonus payments in the CHIP program, the reauthorization program. We anticipate about $6 million in that particular bonus. Item number 13, to maintain 11 months of the CMO capitated payments. You'll recall we're making 12 payments this year in order to draw down additional stimulus funds. We'll be making the 11 payments in FY12. Item number 14 reflects the discontinuation of the increases in the stimulus FMAP funds and replace those with state funds, and you can see that this is an addition of $321,000. When you add the other state funds that I mentioned earlier with regard to age, blind, and disabled, that totals nearly 600, or right at $600 million. Peach Care is the next programmatic area. Peach Care obviously is comprised mostly of children. It tracks the Medicaid program, and so you'll see many of the same items here. The implementation of co-payments related to Peach Care members, that saves about $1.5 million. Item number 2 reflects an increase in the federal participation rate, the FMAP rate. That is about $305,000 in savings there. Item number 3, again, maintain the 11 payments to the CMOs this year, and that will be reflected in the budget. Item number 4, reduction in the reimbursement rate to providers of about $700,000, which would apply to Peach Care beneficiaries. Item number 5 would be to remove the CMO outpatient reimbursement floor in Peach Care. That saves about $590,000. Item number 6 is reflects a reduction in funds related to the drug rebates in the CMO provision, and that saves about $6.6 million. The final area, programmatic area, is the State Health Benefit Plan. As you know, the State Health Benefit Plan is composed of 3 plans. One plan is related to state employees. The second plan is related to teachers, and the third plan is related to non-certified personnel, school personnel. I've provided a couple different charts for you here today. The chart that you see here, you can see in the green is the non-certified personnel of about 179,000 members. The state employees is about 172,000, and nearly 50% of the composition of the state health benefit plan, 330,000, relates to teachers. I wanted to talk for just a second about the financial status of the state health benefit plan. We put a few charts together here. You can see this is the overall. When you combine the three together, those three plans together, you can see the revenues in blue, the expenditures, and this is for FY11. The expenditures in red. The green is the surplus from the plan in FY11, and you can see the purple there reflects the incurred but not reported liability. So we will, looks like, having a bit of a deficit this year if you include, and we don't include this on the in the budget, but it is on the financial statements as an incurred liability. So we'll have a bit of a deficit in the state health benefit plan. I think I've got that right. In the next chart, you can see that same information broken out by each of the categories of plans, the state employees, the teachers, and the non-certified school personnel. I think if you look on the last column there to the right, you can see why we have one of the line items in the budget, which is to reflect the increase in premiums for the non-certified personnel. You can see that the revenues and the expenses don't quite match up there, and there's a significant underfunding in that particular area of the plan. I'd like to draw your attention also to the next chart, which is a new chart. This relates to net assets of the state health benefit plan, and as you can see from FY 2005 through FY 2010, FY 05 to 08, we continued to build assets in the plan, and due to our budget circumstances, those funds were utilized to help balance the budget. In FY 10, you can see we running a deficit of about $220 million, I believe. In the governor's budget, there is some movement on that. I think there's about $56 million to put some more funds back in allocated to the reserves. I believe we have about $17 million in reserves right now, which is a pretty narrow margin regarding the daily payments that we pay out of the plan. Most private companies, as my understanding, have about a month to 6 weeks of reserves that would reflect, with regard to the state health benefit plan, of $330 million. So, turning to the budget aspects of the state health benefit plan, item number one reflects $75 million to recognize the revenue generated from employees with dependents up to age 26. That is one of the, you asked about the National Health Reform Bill and what we've done to implement it. This is one of those things that we've done in State Health Benefit Plan to implement that. The second is to increase the per member per month billing for the non-certified school personnel. That relates to the graph I showed you earlier, where that's in a significant underfunded basis. The amount of that increase, in order to bring that to zero, would have to be about double the increase. So while we're making progress on that, we're not all the way there in terms of meeting expenses to revenue in that regard. Item number three would implement additional plan changes in the state health benefit plan to reduce expenditures by about $37 million. Item number four is to reflect updated revenue and expense projections of about $19 million. Item number five is to reflect the depletion of prior year reserves of $60 million. Item number 6 reflects the projected cost of the federal health reform related to covering 100% of preventative coverage, and that is about $10 million. Item number 7 reflects the projected cost of changes related to coverage of dependents under the federal reform, national reform bill up to age 26. That's an additional $113 million. Item number 8 reflects the projected reimbursement that we hope to get through the early retirement reinsurance program. My understanding is we've already collected $35 million from that particular $5 billion fund so far this year, and we're either, I think it's this week, we're submitting another request for additional reimbursement from that fund. Item number 9, increase the employee premiums 10% in plan year 2012, generates almost $30 million. Item number 10 reflects the increase of funds related to the increase in the spousal and tobacco surcharges. That generates about $16.5 million. Item number 11 reflects reduction in the employee premium due to the elimination of the OAP option, the PPO option in the state health benefit plan. That saves about $37 million. Item number 12 reduces expenditures related to the elimination of the PPO plan of about $235 million. Item number 13 is a note in the budget related to the delay of implementation of direct billing for the state health benefit plan employer contribution. And finally, there are 2 items related to general obligation bonds. One is $10 million to work on eligibility system for Medicaid and others, and second is to $500,000 related to facility repairs statewide. And with that, Mr. Chairman, that concludes my brief presentation.
Thank you for a good presentation. I think we've got a couple of questions for you.
Yes, sir.
And we'll start with Representative Shelton. You have a question now.
I just have a couple of questions. Thank you for your presentation. I appreciate you putting that together. On page 9, looking at the tracking document, age-blind and disabled, I see that reflects savings from elimination of underperforming contracts. Will we be putting that contract out for bid again in the ABD?
Is that the disease management?
Yeah.
I'm not sure that that's, we don't have any current plans to put that out for bid again.
Is there a reason? Yes, on the tracking document. There will limit. Is there a reason
we're terminating that contract for failure to perform?
Will we look at that again in the future?
Absolutely.
Okay.
Yeah, we need to be doing that kind of work, but
right.
We don't have any current plans.
Okay. I have one other question. On on the slides, I was looking at slide number 47, and I don't know, it seems like there's maybe some little information missing. I see the state, teachers, and school, but I don't see a little thing for the regents. Could you get me that information, please?
I'm not sure that's in my department.
All right, just trying.
I think
I think we're going to be getting some of that information for you Monday.
Thank you.
Okay.
Thank you.
Representative Stevens.
Thank you, Mr. Chairman. I'm looking forward to that information myself. On 1733, you're talking about the transfer of funds from corrections to Medicaid to reflect those medically fragile. How did y'all get that number? Did the Department of Corrections just send you over those people that were?
I think this, and staff can provide additional detail, there are a small number of medically fragile inmates, I think it's about 15, who were trying to move from the Department of Corrections, and once they are discharged from corrections to another status, if we had a nursing home where they could be discharged to, we would be able to get federal matching funds, et cetera, so it would reduce those expenditures, and they would be eligible for Medicaid at that point. I think that's part of the idea.
And I guess the next question might be, if I may, Mr. Chairman, is since we've got a backlog of some of these medically fragile people that are, and I'm granted the number is relatively low, and I know their cost is very high.
Right.
We might also look at some of our county jails that have some of our prisoners in there, and I'll toss that over to the Department of Corrections. That might also offer some of that up to relieve and draw down federal dollars if they're not a threat to mom in the nursing home.
One of the key factors in this is the classification, whether you're convicted or not. And I know a lot of the people in a county jail would not have the status of being convicted yet. So,
and some
I'm
do.
not sure. Yeah, that would have to be looked at in part of this, but it makes sense what you're saying.
Representative Hughley.
Thank you, Mr. Chairman. I was also interested in that slide number 47.
Turn that on.
Slightly different reason when you're showing us the financial status of the. I'm on?
Yeah.
I'm sorry. You were showing us the financial status of the various parts of our health benefit plans.
Yes, ma'am.
And you're showing that the non-certificated personnel going to have a pretty significant increase in their premiums, and you say it's because of their outcomes. Can you explain to me why they're not all in one plan? I mean, insurance is normally based on large numbers. Why are they separated out like this?
Well, that's a good question. It would be nice to have this run more like an insurance plan, but
okay, it looks
they're
like
all in one.
Okay, it's just the way they. Okay. I was thinking, why would we have them? Okay, all right. The other question I have would be, you mentioned several times about testing that's available in the private sector, and you're not going to do AIDS testing and a lot of these other testing. What effect is that going to have on the population in general? Do you think people are going to pay to have these done somewhere else, or why do you think that can be done in the private sector and we just no longer need to do this after having done them for such a long period of time?
Well, we do know it can be done in the private sector, and I think the question is, are people's behaviors going to go towards putting out their own private funds in order to get that testing?
That's my question.
I think we need to,
what do you think will actually happen?
Well, I don't know that
You're
we've
telling
done
us
any
the state's not going to pay
projections
for
on
it.
that.
I just want to know what's going to actually happen.
Well, I wish I could predict that and project it. I'm not aware of any projections as to what the impact of that would be. But I think there is increasing knowledge and information about AIDS over the last many years, and I think the public will respond to that.
Well, of course, AIDS is just one of the tests, because there's several places in the budget that you're talking about eliminating that and sending it out to the private sector. I was just wondering.
Well, water testing and fluoride testing in the water.
Okay. You can go ahead.
Okay. Representative Gardner.
Thank you, Mr. Chairman. I have several questions. Several years ago, this has to do with the state health benefit plan as well. We decided to select two competitive plans or insurance companies as a way of saving money. And I'm still looking to determine whether we've saved money. And can you tell me about the enrollment? I guess the two plans are United and Cigna.
Correct.
And are they competing in a way that was anticipated?
I think, and Trudy Mason is here, she can go into that in more detail, but the part of the idea was to simplify it as well, in addition. So, and I do know that about 95% are in United and about 5% in Cigna. 90-10 split. Do you have any other comments on that?
So I guess what is the
Does that
impact?
answer?
And of course, I guess while I'm asking the question, Kaiser was eliminated as part of that process. And what considerations are you making for the future?
Well, one of the things regarding Kaiser in particular that we immediately have seen the savings in is the administrative costs. That saved us about $10 million, mainly because of the elimination of avoiding the premium taxes and the retention fees that go along with a fully insured product. Because we were looking to have a self-funded methodology payment where we could get a better deal with the administrative fees that are associated with the self-funded arrangement. So we were able to see savings there, and it also would have brought us about $47 million or a little more over the lifetime of the two contracts that we have in place with United Healthcare and Cigna regarding the administrative fees that we're paying to them. It was a strategic move to go to two vendors. One, as the commissioner stated, to simplify things for us, but also to select two vendors that could provide all the products that we were looking at on a statewide basis to get additional advantages from better discount arrangements with the networks, as well as to have two vendors that could bring a more integrated solution. Prior to our procurement, we were working with several different vendors. That wasn't working very well as far as coordination of the plan programs. It was also a recommendation at the time by the consultants that we were using. So I think overall we are now seeing a negative trend in our medical utilization with the vendors, so that in itself brings savings to the plan.
I can see that it's significantly simplified if most everybody is signed up for one plan. I mean, that certainly is a simplification, although the objective, well, as I understood it, was it for the plans to compete with each other. Would you mind putting that analysis you just gave me on paper? You probably have it somewhere. I'd be curious about how you projected that the savings would occur and whether they have in fact occurred. And thirdly, when is the procurement process? I mean, is this an annual thing? Does it happen every 5 years?
The procurement, it does happen every 5 years. Those are 5-year contracts. They are due to end, I believe, in 2013.
Mm-hmm.
So we will be looking at going back out to bid at that time.
So there will be no changes until 2013.
That's correct.
And
Well, there will be plan changes for the next plan year related to this budget, $37 million.
well, I did want to ask about that.
yeah,
I guess you'll tell us in more detail what those changes are.
Right. We're anxious to get started on that and bring that together. I think part of that discussion also has to include looking at the reserve funds that we have and also doing something in terms of the unfunded liability in the retirement system as well. So my idea is to bring all these together. There will be some impact with national health reform as well coming in down the pike too. So I want to take a look at all that in a global package, and we'll hope to have something, at least some basic recommendations together within the next few months.
And your reserves that you currently have would last how many days?
I think it's about 2, is it?
About
2 to 4 days. 2 to 4 days.
That should make us all a little nervous.
I think they're spending about $8 million a day paying
right.
claims.
Right.
So that's how fast that goes. Representative Stevens, you have a question?
Thank you, Mr. Chairman. Just one more here on the increase in to respect spousal and tobacco funds from $10 to $20. 2 questions. Can you get us the difference in what we're subsidizing tobacco-related illnesses for the? I know last year the Medicaid side it was like $500 million a year that we subsidize that. Can you tell us what it'll be on the state benefit side, and also what that number would be if we were to move it to $25? How much savings that would generate?
Sure. I think we can do that. Yes, sir.
Thank you, Mr. Chairman. I'm going back to your slide number 38 under your age, blind, and disabled Medicaid. This item number 1 is generating some questions for me, and I want to be able to explain to people why it is a good idea for us to eliminate the optional benefits for adult vision, dental, and podiatry services. Why is that cost effective?
I think it's That's I think, a complicated answer. Obviously, the more you provide primary care and other health benefits, the healthier population you have. The other is the reality of our budget, and the other is the reality of federal law related to maintenance of effort with regard to Medicaid, and the reality of 2014 looming, where we're looking at adding another 600,000 Medicaid patients to our rolls. So we have to take a hard look at what services we provide. Areas we are prevented, quite frankly, from making adjustments in many other areas because of federal maintenance of effort requirements. So this was one area where we could make some adjustments, and this is where the governor chose to make those.
Well, help me then understand, in emergency kind of situations, particularly for dental, those people are not going to disappear. They're going to just show up other places in our system. So help me with how that's cost effective.
Any ideas? Nope. I don't have any data on whether that's going to be cost effective, except for the fact that if people don't utilize those emergency room services, it would be cost effective. We do know that this will reduce the expenditures by about $6 million. Medicaid is an entitlement program, and because of that, it's pretty hard to project what kind of utilization you're going to get, including hospitalization. So I don't know, for example, the number of patients that would present in an emergency room to have a dental situation taken care of, but we could certainly look to see if we could get that information for you.
Commissioner, help me to understand, so that we know exactly what we're talking about the vision, the dental, and the podiatry service. As I understand it, the dental is basically just emergency services only, like extractions. It's not for having your teeth whitened and this kind of stuff like that.
I think the emergency is covered by Medicaid. I mean, that is the basic Medicaid if it's an emergent situation. This would be related to basic dental services for the adult population.
That's not what we're eliminating?
Yes, we are eliminating that latter category, not the emergency component. Am I wrong on that?
No, that's not. I don't.
Sure.
Yeah, we need some clarification, because there's been a lot of conversation about this, and we want to make sure we kind of understand.
Sure. Mr. Chairman, as the Commissioner said, these are not good choices. These are not things that we would like to do. However, these are services in the adult dental, for example. We cover, in adult dental, we cover basically emergency services only today for adults. The exception to that being pregnant women. There is an expanded benefit for pregnant women. This item would remove all of those including pregnant women and the adult dental. That removes the service. So if an individual in the example that Representative Hughley gave presented at the emergency room, that service would not be covered at the emergency room either, because it's removal of adult dental service, not adult dentist services. But the federal requirements are that these services are optional. It's not specific to a provider type. So again, that type situation that you mentioned would be an uncompensated care type encounter.
Well, let me ask you a question about that. If this patient has an abscess, and they show up at the emergency room running a fever with an abscess and this sort of, they're not going to be treated at the emergency room? Is that what you're telling me?
No, I was saying we're not going to pay for it. I'm not going to say they're not going to be treated. The EMTALA would not allow them to turn away an emergency situation from a hospital. This goes toward the uncompensated care.
Right, but if that doctor treats them, and in his judgment they have an abscess, they have an infection, and he writes them a prescription for an antibiotic or whatever, the hospital or the physician neither would receive any compensation for that, just like if it was a medical treatment for some other ailment?
Not for Medicaid.
Okay. How about giving us a little bit of an insight into the vision and the podiatry, what's covered and what would be eliminated?
Right. Under the vision services are more limited to the optometry type services in terms of the eyeglasses, the eyewear, things like that. And then with podiatry, they're more of the routine foot care type services that a podiatrist would deliver. it would eliminate the service, right? And again, these are not good choices that we'd like to come to you with, but those are the choices that the options that are in the budget.
Also having to do with Medicaid, but the rebidding of the CMO contracts, I understand there was an RFP that had been created and the contracts were going to be renewed in February. What is the current plan for rebidding those 3 CMO contracts?
We are in the process of taking a global look at the whole CMO structure in Medicaid. As a consequence of that, we have asked DOAS for the ability to extend our contract for a year, so that would give us a chance to look at it from a global perspective with the new administration. That approval just came down a day or so ago. We have a letter ready to go out to the CMO providers to advise them of that. We'll be renegotiating a contract for a 1-year period is our intention, and come back in less than a year with a solid relook at the whole system.
That is of interest to me, as well as whether, as part of that looking at the contract, will you consider whether having a 12-month renewal recertification process, how that would impact on the CMO's ability to provide us with quality assurance information and other kinds of information? I mean, I think currently
Right.
they're recertified every 6 months as opposed to a year, as in many other states.
Right. There are a few issues like that. As long as we don't get too expansive, we'd have to go through the reprocurement process, but there are a couple of issues that we're wanting to raise and look at in that process.
Other questions? Okay.
Didn't know the answer, so I'll ask you. In terms of patients that have diabetes, the absence of podiatry services, what effect will that have on that population? Are they going to just lose those limbs, or what are you saying?
Question?
No, as part of a routine visit for a diabetic, the physician should be checking the feet anyway. That would not be coded as a podiatry visit or podiatry service, but instead of as a comprehensive diabetes evaluation. So they would still have access to those type services through their physician visit. This should actually encourage them to get into their primary care or internal medicine physician to have those, and at that same time, well, what is your LDLs, and what are your hemoglobin A1Cs, and are you compliant with other aspects of your diabetes care?
So it will not have any impact. That's what you're saying.
I think that's a global statement that you're making. No, I can't say it won't have any impact. I think that it would be mitigated by the fact that the physician would still be checking the feet.
Mr. Commissioner, would you talk to us just a little bit and discuss, you hit this as we went through the copay changes and how that would affect us, and if we were to go into these changes that are proposed in these copay increases or rates, does any sort of waiver have to be obtained or anything from the feds, or are we at liberty to do that just without any kind of special permission?
The budget proposal calls for an increase in the existing co-payments as well as an expansion to a couple other populations. There are no waivers that are required for this. We would have to submit a state plan amendment to CMS, the feds, for them to review and approve that. All of the recommendations in terms of the co-payment increases are within the definition, the federal definition of nominal. One thing that I would bring to your attention is that within the budget, it calls for application of co-payments to the TEFRA eligible members or Katie Beckett eligible members. That is an optional category of eligibility assistance. However, that optional category falls under the mandatory categorically needy definition. So we actually would not be able to apply those co-payments for the TEFRA waiver eligible individuals, but we would for the Peach Care for Kids. Additionally, current exceptions to that, such as prevention visits, would be exempted from copayment, as well as the exempted population, like those individuals who are institutionalized, hospice, children, pregnant women, etc.
Okay. What sort of time frame are you on? Like you have to have an amendment to your state plan. How long does that take to make that happen?
CMS has been very responsive in terms of approving state plans for us. However, within 90 days, a 90-day period, we should have an approval back from CMS once we submit that. That's the predecessor to that is actually a 30-day comment period once we put a public notice out. So 90 to 120 days.
Can you implement the copays and then you get the state plan approved, or do you have to wait until you get the okay on the state plan before you implement it?
We get the state plan approved first. The state plan, however, CMS's practice is that they will retroactive the approval to the first day of the quarter in which it was submitted. So I don't foresee any issue with a 7/1 date if we go forward with that item.
Okay. Representative Garner, you have another question?
Yes, Commissioner, what can you tell me about the waiting list for the HIV patients in the clinic, the ADAP clinic?
Miriam Bell can help me with that, I think. The details. The Acting Director of Public Health.
Good afternoon. There are currently 893 patients on the ADAP waiting list.
On the waiting list.
On the waiting list.
To get services.
Waiting to get services. And it's calculated at each patient receives care in the amount of about $933 per month. And so when we total that out, it's about an $800,000 deficit that we're at and not being able to meet the needs of those patients.
Now, are these patients, would they be eligible for the pre-existing condition insurance plan that the feds have?
You know, I don't know. I can investigate that.
I mean, I think we have in our budget some indication that the hemophilia patients were beginning to come under PRECIP.
Yeah, they are eligible, but that is part of it as far as they have that 6-month waiting period as well.
They have to have a 6 months wait and a refusal from an insurance company? So is that part of your discussion with the people on that waiting list? I mean, that's
Actually,
a long waiting list.
Yeah, it is a long waiting list. And I'll follow up with Dr. Mangala, who's our infectious disease director, to make that suggestion to him.
Thank you.
You're welcome.
Commissioner, I have one more question for you. You mentioned it in the bond about the money that was set aside for the new management system. To talk to us a little bit about that, about what sort of time frame we would be on to make that happen. And right now, that's a 90-10 match on that money to put that new system in, I think, right?
That's correct as it relates to Medicaid.
Okay.
I think as we look forward to 2014, when we have obviously a lot of Medicaid people coming on board, assuming the Affordable Care Act continues on, is not overthrown in some form. I think it's going to be important, and I've had some discussion with both the governor's office and other commissioners, and both Dr. Shelp and Clyde Reese, the commissioners, and the other health-related entities, and we all agree that this needs to be an across-the-board product that will allow us to make some eligibility determinations not only for Medicaid as that comes in, which is required by the law, but also would need to run the filter as well on state health benefit plan and their requirements regarding automatic enrollment in those plans. So there are a lot of moving pieces in a lot of different areas. The match would be for Medicaid, so we certainly would want to maximize our use of that match. I think this is something that, assuming approval of the bond, we would be moving ahead pretty rapidly on to construct.
Do you have any idea when you would actually have something like that operational?
Well,
if that,
we have to first figure out what that is in terms of how these moving pieces are going to be connected. But I would estimate, in January of 2014. I mean, we would need to have it ready for that.
One of the things I hope you'll consider is you put the pieces of that puzzle together. We've heard from a lot of folks who you go in and apply at DFACS, and then they go and apply for Peach Care, and they go apply for something. Every time it's a different deal, whereas if we had one system, you could apply and get all the information, and then it could go to wherever it needs to go, so you don't have to reinvent the wheel every time you do it. And I think that would be a big help to us. And then the other thing that Representative Garner mentioned about that 12-month recertification through there, too. And I think
exactly.
if we were looking at some of those things.
Right. Those are, that discussion is exactly along the lines of the discussion I've heard.
Great. Other questions?
Can I just add to your question? If that system is to determine eligibility for any public program, and the exchange is set up in Georgia, then that eligibility system would also be used for the exchange subsidies? Or?
It could.
It could.
Potentially.
Potentially. But as you plan the system, I guess you have that in mind?
Absolutely. We're looking at all those questions. I think the focus, particularly from my vantage point, is getting a solid Medicaid eligibility system.
What a wonderful thing that would be.
Yes. And there may be, I don't know, all these issues are on the table being discussed, and I think coming together in terms of one plan of how all these moving pieces work together is going to be the first critical step.
The 21st century plan.
Commissioner, thank you and your department
for
a good presentation. I know there's an awful lot to do, and we appreciate everybody attending, and want to remind you that we'll be having a meeting next Monday. That'll be the 21st at 1 p.m., 406, right here in this room next Monday at 1 p.m. Thank you for attending.
Thank you, Mr. Chairman.